Hello. Hello, sir. Hello, everyone. So maybe we will wait for 2 minutes for the panelists to, uh, delegates and attendants to join, and we'll start at 8:02.
Yes, sir. Yes, sir. After your confirmation, we will be live, sir.
Nobody has yet joined, I think. No.
Hello, sir. Am I audible?
Yes,
So
you
everyone has
are.
joined. So Atma, can you hear me? Atma?
We can hear you, sir.
We
Okay.
can hear you, sir. Yes.
If everyone is ready, then we can start now.
Have participants joined in? Oh.
Yes, sir.
Yeah, sir. They join on different links, sir. So they are watching
Oh, I
us. Yeah.
see. Okay,
Yeah,
then.
yeah.
then
It is in different.
So we are, Rahul bhai, we are live now.
So when you say we,
Yes, sir. Yes, sir.
Yes, sir.
Okay.
We can go ahead, sir. Yeah. Yes.
So, very good evening, and thank you for joining this special webinar, which is primarily focused on the Perampanel. As we know that Perampanel is there in the Indian market for last 3 to 4 years, but with the availability of now, with the generic medicine and with the loss of the patent, now it is becoming available at a low cost in Indian market. And that is why we now the many of us more patients of ours will be able to probably afford it and benefit with the Perampanel. So we thought that it may be a good time to discuss the whatever the real world experience has been with the Perampanel in the last 3 or 4 years. And we thank you, Estera Division of the INTAS, for supporting this webinar. So we have a panel of expert epileptologists and pediatric neurologists who will be taking part in this special webinar. It will be started by none other than Dr. Dinesh Nayak. Nayak sir is a well-known and senior epileptologist in the country, and after his training at Sri Chitra and King's College London, he is one of the prominent epileptologists and working at the Gleneagles Global Health City in the Chennai. And he has been a mentor and teacher to almost most of the young epileptologists in the country. And subsequently, we'll have a talk on the pediatric perspective and use of the Perampanel in pediatric patient. And we have one of the prominent pediatric neurologists in the country, Dr. Lakshmi Narayan, who is also working at the same hospital as the Dr. Dinesh Nayak. And I think everyone who is interested in pediatric neurology knows Lakshmi, a very good clinician and a good academician with a paper publication in the journals like Brain and Annals of Neurology. And then we have another prominent young epileptologist, dynamic epileptologist from the Medanta Medicity Gurgaon, Dr. Atmaram Bansal, who has also been trained at Sri Chitra with us and subsequently is running a successful epilepsy surgery program in Medanta for last 10 years. He will be sharing his experience of the Perampanel in the real world. Following which, we'll have a panel discussion, and for the panel, the senior most epileptologist in the country, Dr. J.M.K. Murthy, who is the president of the IAN, and well-known clinician and academician. I think everyone knows Professor Murthy, so he doesn't require any much introduction. Then we'll have Vinyan KP, which is there, his perspective, especially in relation to the pediatric aspects of the use of the Perampanel. He is a professor and head at the pediatric neurology department at the Amrita Institute in Kerala. And he has been a well-known senior-most pediatric neurologist and attached to the ILE and Indian Epilepsy Society for a long period of time. And lastly, we'll have another panelist, young dynamic epileptologist and my friend, Dr. Neeraj Bahiti, who also again got trained at Sri Chitra and subsequently running a successful epilepsy surgery program at Nagpur. So with that brief introduction, I think we have a eminent panelist and who has been working in the field of epilepsy and especially difficult to control epilepsy for so many years. And I think we all will benefit from their experience of using, especially focusing on the management of refractory epilepsy and use of the Perampanel, how the Perampanel stands in the, as of today in the management of the epilepsy. So I think I will stop with this and I will invite my teacher, Dr. Dinesh Nayak, to start the proceedings.
I see. Thank you very much, Dr. Rathod, for the very kind introduction, very kind words that you spoke. And it's a great privilege. I thank INTAS for giving me this opportunity to be part of this very elite and eminent panel that we are having. My job is basically to lay down what is Perampanel in the first place. And then my colleagues, very eminent clinicians and academicians, they're going to discuss more on the indications and other things, the actual use of it. So the topic given is that Perampanel, a molecule with a difference. So let's see what the difference is. So that's something that we'll have to look at. And if you look at it, it's a third generation anti-seizure medicine. And the unique part of this Perampanel is that it was developed specifically knowing the mechanism of action. So once they studied the glutamate and the NMDA and the AMPA receptors, and they knew that by experiments that the AMPA receptors are responsible for the generation of seizures or propagation of epileptic activity, then they started going backwards and trying to find out, going forwards and then trying to find out how do you block this AMPA receptor. And that is so that way it's a kind of a designer molecule. So this is the first designer molecule for epilepsy actually, where it was specifically designed to block a particular receptor. And so that's what it is. So finally, we have this molecule, which is a selective, non-competitive AMPA receptor antagonist. So it goes and blocks the AMPA receptor, and I'll show you how it does it. Now, in India, it has been approved for the use of for its use in partial onset seizures as adjunctive therapy in patients above the age of 4 or above, and for primary generalized tonic-clonic seizures in patients aged more than 12 as adjunctive therapy. So that's been given the approval by the Indian authorities. Now, before we actually understand, so we need to have a basic understanding as to how an action potential is generated. You have to have the basics right. So that's the reason why I'm going to spend the next about 5-7 minutes on this, and then only go into the topic proper. So you look at this arrangement. You have you have these synapses between so you have what is called a presynaptic neuron. And then you have a presynaptic neuron, and then the postsynaptic neuron. It may be excitatory, it may be inhibitory, whatever it is, they make a synapse with each other. So, and then each of these will have channels. You have voltage-gated sodium channels, you have voltage-gated potassium channels, calcium channels, and then you have vesicles within the nerve terminals. And these nerve terminal vesicles, which contain either the inhibitory or the excitatory, depending on the type of neuron. The excitatory neurotransmitter is glutamate, the inhibitory neurotransmitter is GABA. Whatever it is, they get released when there is an action potential that comes down that particular neuron. So for example, if an action potential has been generated in the excitatory neuron up above, comes down, and then it it releases, it activates that synaptic vesicle, and then it releases that particular neurotransmitter, and that crosses the synaptic junction, and then it goes and occupies the receptors on the postsynaptic neuron. That's the arrangement. Now I will go into the mechanism of action. Basically is that Perampanel acts on the AMPA receptor that we know. I'm going to now go into a little more detail about what the excitatory neurotransmission is all about, which actually the most prominent one is the glutamate, which actually mediates the fast excitatory neurotransmission in the central nervous system. Principal excitatory neurotransmitter, and that acts, the glutamate has to go and occupy a particular receptor for it to get it to get it work. So that's what it is. So in the postsynaptic membrane, you have these receptors which receive the glutamate. So you have three kinds of receptors, which is the AMPA receptor, the NMDA receptor, and the kainate receptor. So these are the three receptors which are in the postsynaptic membrane, and they are glutaminergic. Now, the AMPA receptors itself, they are the most abundant ionotropic glutamate receptors in the mammalian brain. So they are ubiquitous. So that means they contain, they're all over. And predominantly they're localized, as I said, excitatory synapses and postsynaptically. So the AMPA receptors are the ones that mediate the fast response to glutamate. And I'll show you this. That's what it is. So this is the glutamate. It goes and occupies this receptor, opens that channel, allows the sodium to enter in, and thereby generate what is called an excitatory postsynaptic potential. And if you have enough excitatory postsynaptic potential, then they summate and then produce action potentials, which is extracellular. So EPSP, or excitatory postsynaptic potential, is intracellular, and multiple EPSPs then generate the extracellular action potentials, which then travel along the neurons like that and goes to the next synapse. So that is how it generates. Now you have two kinds of, we said that there are actually three, but now let's concentrate on two, the very important ones. What's the difference between the AMPA receptor and the NMDA receptor? We said that both are glutaminergic, but the AMPA receptor is the main receptor mediating the rapid effects of glutamate. Very important. So it underlies the fast component of the excitatory postsynaptic potential. On the other hand, NMDA receptor does not contribute to fast neurotransmission. So what it does is underlies the slow component of the EPSP. So the EPSP has got actually the two components, the fast component and the slow component. And the slow component is involved in neuronal plasticity, especially in terms of learning and memory. So the NMDA receptors are very important for generating new learning as well as to storing memories. That's very important. And that's the reason why NMDA receptors are so important. And you have these NMDA receptor encephalitis, which produce a lot of problems. On the other hand, the AMPA receptors are the fast EPSPs. They generate the fast EPSPs. And then what happens here is that because it is fast, it contributes to the fast component of the EPSP. So the AMPA receptors drive the EPSPs, and the synchronized EPSPs produce what is called a paroxysmal depolarization shift. That's a very important component again. The later component is the NMDA receptor, but the initial component of the paroxysmal depolarization shift, which is very important from the point of view of generation of seizures, that is actually generated by the AMPA receptor or mediated by the AMPA receptor. And you can look at it. So you have individual neurons and they may be hyperexcitable. So, but it needs a summation. And this summation of individually active neurons, they need to get summated. And that is the job of this paroxysmal depolarization shift. A single neuron is not able to do that. A group of neurons, they come and add together, summate, and then produce what is called a paroxysmal depolarization shift. And this fast component is invariably a job of the AMPA, the glutamate going into the AMPA receptor and then producing this paroxysmal depolarization shift. And the beauty of this is that if you inhibit AMPA receptors, it eliminates epileptiform activity. On the other hand, if you block only the NMDA receptor, it is not able to block fully the early components. That's what happens. So that's the control, and that's the NMDA receptor block. You still get this paroxysmal depolarization shift. On the other hand, you block the receptor here. So what happens, very attractive theoretical advantage of an AMPA receptor blockade is you can actually block the epileptic activity without compromising on the NMDA receptor activity, which is important for neuronal plasticity and the brain plasticity and the ability to learn, ability to memorize, ability to. So that's the beauty of this particular concept of AMPA receptor blockade. Now you have two sites of the glutamate binding sites on the receptor. One is called the competitive binding site, and then the non-competitive binding site. When glutamate is not occupying these receptors, these sites, the channel is closed. Moment glutamate goes and occupies this receptor, the channel opens, allows the sodium ions to get inside, and then it induces an action potential that progresses. So that's what it is. And as soon as his job is done and the glutamate disengages from the site, the channel gets closed. Now let us see what happens when you have a competitive antagonist to this. So you have glutamate, but you have now supplied with some glutamate antagonist, which then goes and occupies that same thing. So the glutamate is not able to occupy it. So therefore, the channel remains closed. So you have a competitive antagonist to glutamate, to the AMPA receptor. You will be able to close the channel. But there is a problem. When you have a lot of glutamate, this lot of glutamate will be able to displace this because by competition. So the number, this is a numbers game. So when you have a lot of numbers, it's able to displace the minority. And therefore, a competitive antagonist is not very good in the presence of a large amount of glutamate. So it fails. A competitive antagonist is not able to overcome the glutamate action. So that is what it is. On the other hand, in the presence of a non-competitive antagonist, now howsoever number of glutamate molecules are there, it is not able to displace because it's non-competitively bound, and therefore the channel remains closed, howsoever much or howsoever many glutamate molecules are there here. So this amount of glutamate will be able to displace a competitive antagonist, but it will not be able to displace a non-competitive antagonist. And that is what Perampanel is. The Perampanel is a non-competitive antagonist, and therefore it is able to keep the channel closed. Therefore, it is not allowing the glutamate to act on the channel. Therefore, you're not able to propagate the action potential that has been generated presynaptically. There is a failure of action potential or EPSP generation postsynaptically, and therefore it blocks the thing. So the anti-convulsant effect of Perampanel stems from disruption of the coordinated network activities. So that's very important. I showed you a particular slide where the groups of neurons, the networks, and moment you block these AMPA receptors in these networks, you're able to get. So it affects the entire network rather than just a few neurons. So that's an important component. Now let's come to the pharmacokinetics and some aspects of dosage. It's perfectly absorbed. The one interesting aspect is it's got a very long half-life. Once you reach steady state levels, the half-life is actually 100. It's not 100 days, sorry, it's 100 hours. Sorry about it. 100 hours. So that means, it's about nearly about 5 days, 4.5 days. So it hangs on in the body for about 4.5 days. and it's quite protein bound, and it is mediated by the metabolism is mediated by the P450 system, CYP system, and therefore it gets affected by enzyme inducing anti-seizure medicines. It can kind of lower the levels. I'll come to that. Maybe it's potentially safe, but it's still category C. It comes in 2 milligrams to 2, 4, and 6 milligrams. So the maximum dose is 12 milligrams a day. Because of its long half-life, you can give it as a single daily dose. So therefore, you are able to manage the compliance. Because of that, you need to have a slow titration, and every 20 days you do that. Now, that's what happens. So the efficacy of Perampanel is lowered when co-administered with enzyme-inducing drugs. For example, if you have carbamazepine or phenytoin or topiramate, you will see that there is a decrease in the level of Perampanel concentration. So in the presence of these drugs, then you'll have to probably increase the dose of Perampanel. On the other hand, the influence of Perampanel on the anti-seizure concentration, other drugs, is very modest, but this is what happens. So enzyme-inducing drugs, you'll have to probably increase the dose of Perampanel to result in the same efficacy. Now, if you look at the common adverse effects, you can clearly see that this is dose dependent. The smaller the dose, the less the side effects. But as you increase the dose, most of the adverse effects are generally mild. They are dizziness, somnolence, headache. These are the usual ones. But there's a percentage of patients who actually have problems like aggression and hostility, and that also is, you can see here that it's dose dependent. The higher the dose, the incidence is higher. But when you add with, say, if it is concomitantly, if it is used with levetiracetam, there's not much difference. I mean, the hostility is not, or the aggression is, it's probably slightly less than levetiracetam or than with topiramate. So that's something that has been shown. But nevertheless, there is a black box warning, which is that you can have sometimes serious psychiatric changes, behavioral changes, and homicidal or suicidal thoughts. So you got to be careful with that. In the European Medicine Agency, they have not found any major problems of reproductive effects, but then you got to be a bit careful because we still don't have much data on this. So it is still category C. So we'll have to be careful in using it in women of reproductive age who are contemplating pregnancy. Now, the spectrum of efficacy very wide. As you can see that all focal seizures, focal onset seizures, best responses for focal to bilateral tonic-clonic, primary generalized seizures, myoclonus, very good for both positive myoclonus, negative myoclonus, reflex seizures, atonic seizures, tonic. So it has got a very broad spectrum of activity. And there are studies that show that in some of the more difficult ones like Lennox-Gastaut syndrome, it seems to be pretty good. And several studies have shown that there's a significant reduction in different seizure types, both in pediatric as well as in adults. We'll be discussing that at a little later point. And in a specific entity called lissencephaly, it may be the preferred drug because AMPA receptors are expressed maximally in the migrating interneurons. And therefore, the neurons in lissencephaly are generally these immature migrating cells, which have a lot of AMPA. So it would make good sense to kind of block the AMPA, and then you may have a better outcome. I've had a personal experience recently. I've just added in a child with lissencephaly, and the child has become almost seizure-free. So that's what it is. Maybe in genetic epilepsies, maybe a good choice. Dravet syndrome, CDKL5 encephalopathy, and some SYNGAP1 mutation associated encephalopathy, and Angelman syndrome. And because it acts on the network hyperexcitability, it may be a good option for these very difficult to control epilepsies like LAFORA, the progressive myoclonus epilepsy syndromes, refractory cortical myoclonus. And some people have used it in status epilepticus. You give a bolus to start with, straight away hit hard initially, when it's especially in refractory. If the initial period just before the RSE phase, if you use it, may be a little better. There are some studies which show that it can be used in that. The other important thing is that it has a significant effect on reflex epilepsies, especially cortical reflex myoclonus and all that, because it kind of produces temporal dispersion and it inhibits the paroxysmal depolarization shift that I showed, and therefore it can be a useful molecule in that. And there's a very interesting component here. If you combine it with zonisamide and perampanel, because of their differing mechanism of action, you could theoretically have a good combination in your hands. And probably that would be a good point. And I'm not going to go into the study because this is an Indian study which has come out, and over years, see, it was initially it's a multicentric, phase 2, phase 3, double blind, and then followed by open label. So you have a long follow-up of 4 years, and it's been pretty effective across all doses. This is the Indian population, there's a non-Indian population, and generally it has been comparable, and the adverse effect profiles also are pretty comparable. So I'm not going to go too much into those things because we know these data that is pretty robust. So these are the indications that it seems to work for almost all across different seizure types. And I think I would end there. I think I've just completed on time, 25 minutes. And I would now hand it over to my very distinguished colleagues, Dr. Lakshmi Narayan and Dr. Atmaram Bansal. They are going to talk much more about, I just laid the foundation as to why this molecule is a little different from others and its mechanism of action, because then we can have a good understanding of how we can use it. Thank you very much for your attention.
Thank you, sir. Thank you for summarizing the pharmacodynamic and pharmacokinetics of the perampanel, and then detailing the indications of use of perampanel. I think that foundation has been set, and now I invite Dr. Lakshmi Narayan to share his experience and views on the use in pediatric epilepsy.
Good evening, sir. Very good evening, all of you. Sir, I need to get the sharing rights. I'm not able to share.
Oh, wait, I'll stop share. Yeah, now you can. Probably.
Yeah.
No?
Are you able to see my slides?
Yeah, Lakshmi, please go ahead.
Yes, sir. Very good evening, all of you. So in next 20 minutes, we'll see some of the experience in pediatric drug-resistant epilepsy, role of perampanel. This has been already covered in detail. So it has a unique mechanism of action, very long half-life. So especially in teenagers and young adults who are going to be notorious for missing doses and compliance issues, this once daily will definitely be of help. Broad spectrum of action. It's approved for both focal as well as generalized epilepsy, both secondary generalized as well as primary generalized tonic-clonic seizures. So it is useful across all the seizure types, seizure spectrum, including myoclonic and other seizure types where some of the other medications can have problem. And this is one of the ideal anti-epileptic drug for combining with all other anti-epileptic drugs in the rational polytherapy. So the efficacy has been shown to be similar in pediatric age group also. That is one of the most important message first. The efficacy data, what we saw earlier in adult, it holds true for the pediatric age group as well. But we do slower titration. We start with, I'll come to the doses, but we'll start with the lower doses, and we only increase the doses every 4 weeks or so. So slower titration is always better. That holds true for perampanel also. And the seizure control should be reassessed after a dose of 4 to 6 milligram in pediatric age group, especially younger children less than 8 years of age, because most of the children 4 to 6 milligram is one of the effective dose. So we need to be careful about going beyond 8 milligram per day in pediatric age group, because that is when you start seeing more adverse effects. And the enzyme inducing anti-epileptic drugs need a higher dosage. Adverse effects, commonly dizziness, somnolence, and headache. And FDA black box warning has already been discussed. So this warns about severe psychiatric and behavioral side effects including aggression, hostility, and homicidal tendency. That is one of the most severe side effect has been associated. Fortunately, it is less common, but you need to be careful about these adverse effects. Some of the peculiarities of pharmacokinetics and dosage in pediatric use. This has been found even though there is a milligram per kilogram dose given. You can start with 0.1 milligram per kg, can go up to 0.18 milligram per kg in children. But the most studies that have studied the pharmacokinetics of perampanel in pediatric age group has concluded that the perampanel serum concentration is age and weight independent. So most of the times, rather than calculating the mg per kg dose for use, we use almost similar flat dose like 2 milligram, 4 milligram, 6 milligram, and 8 milligram in pediatric age group also. This is one of the peculiarities because most of the other medication we'll be using only less than half of the dose that we use in adults. But here we use almost 8 milligram per day. So we start with 2 milligram per day. In very young children, we start with 1 milligram per day, but most of the older children, about 12 years, we start with 2 milligram per day and titrate slowly upwards to 4 to 6 milligram per day. And usual adverse effects in pediatric age group, usually we come across after 8 milligram per, 8 milligram per day, not 8 milligram per kilo. So again, in personal use, we have seen many patients developing aggression, behavioral side effects, including hitting others and irritable behavior. One child particularly had laughter episodes on 8 milligram per day. But the advantage of this is, like many times you titrate upwards, the moment you hit the adverse effects, then it is reversible once you come down on the dose. So if you start seeing adverse effects at 8 milligram per day, you can go back to 6 milligram per day, and many times the adverse effects are reversible. So you don't have to withdraw just for these. So coming to the indications for use, we need to know the indications in US FDA and European so that we can understand our indication, because any medication, any newer anti-seizure medication are usually first licensed for above 18 years, then above 12 years. Over time, when we start accumulating data, it is approved for younger age group. One of the peculiarities of US FDA approval is it approves perampanel as monotherapy also. No other nation, no other country has a monotherapy approval for perampanel as of now, but US FDA approves monotherapy as well as adjunctive therapy for focal epilepsies with or without generalized seizures, secondary generalized seizures, in children more than 4 years of age. And for primary generalized tonic-clonic seizures, it is about 12 years and it's only adjunctive therapy. So this is the US FDA approval. European Union, the age group is slightly different and it has only adjunctive treatment approval, not monotherapy approval. For focal epilepsy, more than 4 years. For generalized epilepsy, more than 7 years. And that is a recent change last year in the European Commission approval. Indian approval almost overshadows, almost similar to the US FDA approval, but as of now, it is not approved for monotherapy, even in focal epilepsy in India. So we have got adjunct treatment approval for focal epilepsy with the secondary generalized seizures above 4 years of age. And for primary generalized tonic-clonic seizures, adjunctive treatment approval for about 12 years of age. So this is Indian approval. So I will share with you few landmark studies. This is called study 311. This is one of the large studies that has been conducted in age group 4 to 12 years. And this is the basis for the US FDA approving this medication back in 2018 for children more than 4 years of age for partial onset epilepsy. So in this study, basically they enrolled 180 patients, open label study, and here they used oral solution for the same 2 to 12 milligram per day dose. They titrated over few weeks and they maintained for few weeks, and they kept the patients on long-term follow-up for nearly 10 months so that they reviewed the data. If you compare the seizure types and epilepsy type, you have all the seizure type and epilepsy type. So that is again the broad spectrum of efficacy. But one of the problem in this study is this has been primarily conducted in Caucasian and Japanese population, and the other population have been represented very much less. So this is one of the problem in extrapolating this data to our country. If you see the dosage range, mind you, this is the age group of 4 to 12 years. All the children are less than 12 years in this age group, and you can see the dosage used is 6 to 8 milligram. This is the maximum dose used, median dose used. So this is 6 to 8 milligram across all different seizure groups. And if you compare the 4 to 7 years as well as 7 to 12 years also, the dosage per day dosage used is 7.3 milligram per day, 8 milligram per day. So 4 to 7 years also you can use 6 to 8 milligram per day dose. And adverse effects, again, the most common adverse effects that have been reported in this study also: somnolence, nasopharyngitis, dizziness, irritability, pyrexia, and vomiting. This is the same like most of the other studies that have, the incidence is 10 to 20% of patients report these non-serious adverse effects. Coming to the seizure outcomes by the seizure type. So in the median reduction of seizure frequency, if you take almost 50 to 60, 70% of patients, median reduction of seizure frequency is there. The interesting point here in this particular slide is the perampanel is relatively more effective for idiopathic generalized epilepsy, primary generalized tonic-clonic seizures, even compared to the focal epilepsy with or without the secondary generalized seizures. So the first graph here that shows nearly 70% median reduction in seizure frequency in primary generalized tonic-clonic seizures. If you see the seizure freedom data towards the right-hand side, it shows more than 50% seizure freedom in primary generalized tonic-clonic seizures compared to 10 to 20% seizure freedom in focal epilepsy with or without secondary generalization. So one of the messages that we get from this study is perampanel is very effective in idiopathic generalized epilepsy, genetic generalized epilepsy, primary generalized tonic-clonic seizures as well, not only for focal epilepsy. Again, the same data for different age group. Again, you see the same thing. If you go by subgroup analysis of 4 to 7 years versus 7 to 12 years, most across the spectrum, the efficacy data is almost similar, except a few outliers. Say, for example, in the left-hand side, you have median reduction of seizure frequency of nearly 80% in primary generalized tonic-clonic seizures in the 7 to 12 years age group compared to only 56% in the 4 to 7 years age group. But otherwise, all across the spectrum, whether it is 4 to 7 years or 7 to 12 years, the seizure responder rate is maintained same. So it is effective in younger age group also, and it is effective across different seizure spectrum. Another important study, this study is called 232. This is basically a main study for pediatric age group population. The aim of this study was to analyze the pharmacokinetic mechanisms, safety, and tolerability. In this, basically they concluded, this is the conclusion from that study, pharmacokinetic profile of perampanel was independent of both dose and time, as well as not significantly affected by age, weight, gender, race, as well as other parameters. So this was the basis for advocating a flat dose even in younger children rather than calculating 0.1 mg per kg dose. So we start with 1 or 2 milligram per day, and gradually after 3 or 4 weeks, we go to 4 milligram per day. Another 4 weeks later, we go to 6 milligram per day. This is how we up titrate perampanel in children, and this is similar to what we do in adults also. This is a very important meta-analysis, efficacy and tolerability of second and third generation anti-seizure medication. In these 32 studies were included, and nearly 7,600 patients were part of this network meta-analysis. What is a network meta-analysis? Basically, you have different RCTs comparing one active drug versus placebo. In a routine meta-analysis, you will be able to pool data only those same active drug versus placebo. But in a network meta-analysis, what they do, even if it is carbamazepine versus placebo, phenytoin versus placebo, lamotrigine versus placebo, any of the medications as active medication versus placebo, they have a statistical method to pool these data so that we have a meaningful comparison between these active molecules. Otherwise, there is no way that we will be able to compare these different data of one active molecule versus placebo compared to another active molecule versus placebo. In this, what they have seen, responder rate, 50% responder rate for different anti-epileptic medications. And you can see the color coding here. The lowest is, of course, for placebo. But if you see the purple one, that is Perampanel, so it is very effective. It is nearly in the middle. You have the highest 50% responder rate for topiramate, but Perampanel also is very effective and it is in the middle, more than many other anti-epileptic medications. When you come to the dizziness, the significant adverse effect that is quoted for Perampanel, if you see this purple line here, that represents Perampanel, you see that dizziness as adverse effect is much less in Perampanel compared to all the other anti-epileptic drugs that you have. So when a study like this comes up, like Perampanel versus placebo and dizziness in 30%, 40%, 50% patients, then it means dizziness happens so much population. But if you have this network meta-analysis, you see that most of the other anti-epileptic medications also cause similar side effects. In fact, Perampanel is one of the least for producing dizziness. So that is why it is important to have this kind of data analysis. And somnolence, again, you have so many other anti-epileptic medications that causes more somnolence compared to this purple line here, that is representing Perampanel. Same data is displayed in a tabular column here. So this is area under the curve in a different statistic in this network meta-analysis. You will see that Perampanel here is 0.26, 0.37. Again, the dizziness and somnolence, same data that I showed previously in the graph, compared to all other anti-epileptic medication that causes more dizziness and somnolence. And you will be very surprised that placebo also causes dizziness and somnolence. So coming to last part of this talk, our own personal experience of Perampanel using in pediatric age group. As I told you, the approval for 4-year and above for focal epilepsy in India came late last year only. But before that, it was used as open label. And when Perampanel first came into the market 2 years ago, so this was some of the patients. You can see the 15-year-old girl with drug-resistant epilepsy. She had basically a focal epilepsy with a secondary generalized tonic-clonic seizures, having multiple seizures per week, and she has been tried on all the medication. So when the medication Perampanel was first introduced in the Indian market, she was one of those patients like we were desperate to try on any other new medication because she was having so much seizure burden. So she was commenced on Perampanel and completely has become seizure-free now for more than 2 years. She is on follow-up. Last follow-up, I saw her 2 or 3 months ago, and she has been continuing on the medication. So that gives a confidence that more than 2 years she has been on Perampanel, and the retention rate was good. She did not have any side effect. Mind you, she is one of the little bit delayed child with behavior side effects as a baseline, but fortunately she did not have any behavior problems with Perampanel. So she continued on that even now, and she has been seizure free, which she could not achieve with any other anti-epileptic medication. Second child, a 9-year-old boy with severe global developmental delay, again bedridden child with Lennox-Gastaut syndrome with multiple daily drop attacks. He was on 4 anti-epileptic drugs, and many other anti-epileptic drugs have been tried in different combinations, but he was in a desperate situation, we started Perampanel as an open label. Again, this was more than 1.5 years ago, and he has achieved more than 95% seizure reduction. Now he has very brief nocturnal sleep seizures only, that too very rarely. And the third, more recently, 4 or 5 months ago, I started one of the 8-year-old girl with drug-resistant absence epilepsy. She has been tried on all the other medications for absence epilepsy, and still she was having multiple absences. Her genetic report is still awaited. But she has been otherwise intelligently normal child, school going, but she would have multiple absences that would not respond to any combination of different medications, including a combination of ethosuximide, valproate, and lamotrigine, which we use for drug-resistant absence epilepsy. And with Perampanel, she achieved more than 90% seizure reduction in absences. So this again highlights that not only for focal epilepsy and secondary generalized tonic-clonic seizures, Lennox-Gastaut syndrome with multiple daily drop attacks, as well as absence epilepsy and other genetic generalized epilepsy can be a potential indication for using Perampanel, because this is one of the broad spectrum medications, and this can be used in different combinations for rational polytherapy. With that, I conclude. Thank you for the opportunity. I thank Dr. Rathore sir for inviting me for this talk, as well as I thank INTAS for giving me the opportunity. Thank you.
Thank you, Lakshmi, for elaborating the pediatric uses of the Perampanel and your own experience. I think that is quite heartening to note that it's broad spectrum of action and mainly useful in the patients with epileptic encephalopathies, where you know that all the drugs usually doesn't work much. So we have probably a good drug as a new drug in our armamentarium. I think with that, I think we'll invite Dr. Atmaram Bansal for sharing his views, especially focusing on adult epilepsy and his experience of using Perampanel for last 3 or 4 years. Atma.
Thank you, sir. And Nayak sir has given a very good overview of Perampanel, and Lakshmi had experienced very good experience in Perampanel and pediatric epilepsy. So my work is basically to give you an overview of experience in adult of Perampanel, the real world, the scenario, how it started and what is the current status. So I'm sharing my slide, and let me see. Sir, I hope my slide is visible now.
Yes, Atma, please go ahead.
Okay. Thank you, sir. So, as you know that there were initial trials, which were phase 3 trials, study number 304, 305, 306, and they were started on adult, basically patients of more than 12 years who are already on 1, 2, or 3 anti-epileptic drug and had at least 5 seizures, baseline seizures. And these patients were given 2 milligram, 4 milligram, 8 milligram, depending upon response, up to 12 milligram. And it was titrated every week by 2 milligram. And then it was the maintenance phase we started on. Primary endpoint was basically reduction in seizure frequency in 1 month and to see the response. So the response means more than 50% reduction in seizures, or 50% responder rate. So the study clearly mentioned that among these 3 kind of trials, the last trial was basically including Perampanel 2 milligram also. So even at 2 milligram, there was a response of something like 50% responder rate was about 20%. So even in our practice, we had seen that patients do respond to 2 milligram. So, and it is possible that with 2 milligram seeing the response, you may not even need to increase the dose. So based upon these 3 studies, outcome was published, and then secondary outcome was assessed based whether it is showing what kind of percentage of complex partial seizures are reduced. And again, the outcome wise, it was about roughly 35%. And even at 2 milligram, it was about 20%. In primary generalized tonic-clonic seizures, out of about 164 patients, Again, that the dose was titrated and the response was quite good. Almost 76% patient had seizure reduction. And in total, 50% reduction response rate was about in 2/3 of the patient. And the most important or the surprising factor was that about 1/3 of the patient became seizure free. And these were the patients who are already taking anti-epileptic drugs. So this provided a baseline kind of evidence that adding perampanel reduces primary generalized tonic-clonic seizures compared to placebo, especially in drug-resistant epilepsy. So this was one of the study which was done for generalized seizures. Then initial thought was whether it is effective only for short term. As we know that patients who are having refractory epilepsy may have something like a honeymoon period where any new drug may work only for few days and subsequently patient becomes seizure free. So there are long-term trials which were pulled out of these 3 trials and it was labeled as 307. And out of these, at first year, there are about 900 patients, and at 4th year, there are about 78 patients. At 3 years, there are about 436 patients. And seizure freedom was, seizure reduction was about ranging from 40 to 70%. Median seizure reduction percentage was even up to 100%. So this is one of the, you can say, bias kind of thing, because the patient who are seizure free continue to take anti-epileptic for 4th year onward. But even at 3 years, out of, it's a good number at that about 88% patients were having good reduction in seizures. 88% was the seizure reduction. So long-term means it was about 4 years, and it was associated with a good improvement in seizure control, and especially in those patients who had secondary generalized seizures. So there was an extension study again to see the kind of 50% response rate. And again, it was found that patient had about 50% response. So long-term treatment is associated with good seizure control. Then again, it was about the seizure freedom. That was again seizure control, now seizure freedom. So at the age, at 4th year, about 13% were totally seizure free. And secondary GPCS were not there in about 54%. Then comes, there are some studies which have been done nowadays to see whether we can do an early add-on versus late add-on. And most of these newer drugs are being kind of advised that you try early. And that gives a bit of bias, because if the epilepsy is not that refractory, any early add-on drug may show good response. Or if the drug is, if the epilepsy is very refractory, any drug which is added on later is likely to fail. So early add-on study is another study which was presented. And again, the age was more than 12 years, and at baseline, and then at 12 months. So it was found that the retention rate was quite good, almost 83%, and seizure reduction rate was about 50%, and seizure freedom was also quite good. So at an early add-on, about 20 to 30% of the patient became seizure free. And about this particular study, one important point was that there was no significant difference was found whether the patient had been given levetiracetam or not. Even in patient with concomitant levetiracetam, there was no worsening of behavior side. So it had a very good retention rate. Almost 69% had good, some response, 50% responder rate. So this was consistent with the safety profile also, that patient major side effect was not there. And even in patients who are using levetiracetam, there was no aggressiveness. Then another study on early add-on, 77 patients. Again, the results show that retention rate was quite good, and 60% patient had more than 50% reduction. And again, seizure-free outcome was roughly about 40%. So what we are seeing that early onset, early add-on shows seizure freedom in the range of 20 to 30 to 40%. And about 72% patient had the first add-on, and about 44% had other two. So another study on focal onset first add-on study, 85%. And here the focal onset seizure had very good response. Similarly, secondary generalized seizure again had very good response. And even this 100% reduction was found in about 47 to 75% of the patients. So these are small studies. Relatively, the number is not very high. So, but yes, at least this give a flavor that this is a good first add-on therapy for focal epilepsy, in which the monotherapy was failing. Then comes another study, again 81 patients who had failed on more than 3 drugs. And retention rate was again good with Perampanel, if we compare it as first add-on versus late add-on. So at 12 months, seizure freedom, retention rate, responder rate, all were very good in first add-on compared to late add-on in focal epilepsy. And in patient with the tonic-clonic seizure, again, retention rate, responder rate, and seizure freedom rate, all were good in first add-on versus late add-on. So in total, retention rate is high when it is added early. Seizure freedom and responder rate is high when it is added early. So if we see the refractiveness in early add-on, a good responder, a good retention rate means that the drug was effective in a longer period. Then there are some questions whether it is only for focal epilepsy or generalized tonic-clonic seizures. My friend Dr. Lakshmi has already shown good response with the abscess epilepsies. Even it's being tried in LGS, it's being tried in idiopathic generalized epilepsies, JMEs, myoclonic seizures. So there are some studies on long-term efficacy and safety in patients with tonic-clonic seizures, generalized tonic-clonic seizures. So either it is focal onset bilateral tonic-clonic seizure or primary generalized tonic-clonic seizures. So here also, if you see the comparison, even in the patient who had not focal onset, it had the primary generalized tonic-clonic seizure. In fact, primary generalized tonic-clonic seizure had better response rate compared to kind of focal onset. And it was maintained even up to 3 years or 4 years. So that is that means it is not something that you add on and the response is only something like a honeymoon period or a very short period kind of response. Then this is same thing only shown in a different format, that seizure freedom was found even up to 4 years in patient with focal onset generalized seizure versus in patient with primary generalized seizure. So again in the range of 20 to 30%. And so the key point of this study is that it is effective in primary tonic-clonic seizures with a good retention rate, good reduction in seizure, and improvement over 3 to 4 years. This one particular data is from pooled analysis of phase 2 and phase 3, because this Perampanel was tried in India also. And it was found that response rate was something like 100% for generalized tonic. The number is very small, it's only 11 patients. But for others, like even focal onset seizure, the response is something like 60 to 70 to 75% seizure reduction. So it is a suitable drug even for Indian patients. Then this is the study I was talking about, idiopathic generalized epilepsy. Any study being done in idiopathic generalized is quite difficult to do because the seizure frequency is very low and you need to do a long-term follow-up, as the patient may have seizure only once per year. So in this study, 149 patients were taken, and dose was 6 milligram, median dose, but most of the patients were using 4 milligram. And patients were already on more than 2 drugs. And among these patients, 60 patients were JME, 51 GPCS alone, 21 juvenile absence, childhood absence, adolescent absence. And if you see the epilepsy syndrome, this is what they have mentioned at baseline. And the reduction wise, GTCL alone, there was an 80% reduction, JME 66%, absence epilepsy was 71% reduction. Dr. Lakshmi had shown that case where the child was not responding to others. So in this particular study, a patient who are taking 2 drugs and not responding even in absence epilepsy had 71% response. And responder rate basically ranged from 75, roughly around 75%. Most of the patient had response. And worsening was seen, you can say, roughly about 5%, 3% of the cases. So at the baseline, as we mentioned, that number of anti-epileptics were even, at times it was 7 anti-epileptics before this drug was given. And even in those patients, there was good response, about 20% response. So key point from this study is that it improves seizure in most of the patients with regard to the epilepsy syndrome. And all seizures responded, whether it is GTCS, even myoclonic seizures, it responded. Absence seizure, it responded. And seizure worsening was very good. Adverse effect wise, it was again irritable T somnolence and dizziness. So take on from this study is it can be given even in patient with juvenile myoclonic epilepsy without any expected risk of worsening of any type of seizures. So there are, this is probably the last part of my studies, a few more slides. So these are comparison study versus other anti-epileptic. So one of the studies versus lacosamide in the real world scenario. So it is not something like a direct comparison. It was a comparison of different studies basically. And it was found that seizure reduction wise, these are the previous anti-epileptic drugs, the baseline data. The patient who were given lacosamide were having mean anti-epileptic drug 7, while perampanel had 8. And this was the retention rate. So retention rate was quite good in both the cases. Almost 2/3 of the patient had good retention. And the mean dose of lacosamide was about 375. That's what we usually give, around 400 milligram, 300 milligram. And in perampanel, it was 8. Responder rate was roughly 29%, and here it was about 49%. Seizure freedom was 4%, and here it was 14%. So that is something which was different from lacosamide. That seizure freedom rate was far better than lacosamide. Then side effect wise, no doubt that the somnolence was more with perampanel, and this we do see that patients do have significant sleepiness. So should be given at night and should be titrated very, very slowly. Higher the dose, higher the chances of somnolence. Otherwise, dizziness is more common with lacosamide. Lacosamide patients do complain of bit of ataxia, giddiness, dizziness. Irritability was only 4%, and no other major issues were seen. So in total, the result was responder rate was 48% versus 28%, seizure freedom 14%, retention rate was similar. So highlight, both are equally good, both are having a good retention rate, but seizure freedom is more with lacosamide. And another study, this we have discussed basically. Another study is on Fycompa versus levetiracetam. So that was the study that's probably sponsored by this Zai Pharmaceuticals. And what they have mentioned that in patients who are taking levetiracetam with the age of more than 18 with uncontrolled secondary generalized seizures, the baseline data was almost same. Response rate was almost same, whether it is levetiracetam or whether it was perampanel. Only a marginal difference at 6 months. Seizure freedom wise also it was almost same except at 6 months. Retention rate is something which we can see that it was about 26. So it was retention rate was at 12 months it was 86%, and levetiracetam it was 65%. So after 1 year, the retention rate came down significantly for levetiracetam versus perampanel. So in summary, that both had good effectiveness, but retention rate was far better than levetiracetam. Another study has been for comparing systemic review to compare with brivaracetam. And what they could find that perampanel had a better response rate even compared to brivaracetam. And there was no difference whether the patient has taken levetiracetam or not. Adverse events were almost similar. So it showed a improved retention rate, improved response rate compared to brivaracetam. Last two, three slides are about monotherapy of Perampanel. So one is about this freedom study. So there were 91 patients. 4 milligram was tried and at times up to 8 milligram. So focal onset showed 63% and secondary generalized showed 65% improvement. So majority of these patients were taking 4 milligram. So 4 milligram at 26 weeks, showing 2/3 of the patients showing good response, is actually something which we can say that any first line drug, whether with carbamazepine, phenytoin in the past or other drugs, 2/3 of the patient have response. So here also about 2/3 of the patient have response, and the dose required was about 4 milligram at 6 months. This was one of the latest study published on monotherapy in the real world scenario. And here about of one patient at 12-month retention rate was about 55%, and seizure freedom ranged somewhere between 20 to 45%. And responder rate was 50 to 100%, means that generalized seizure patient had some response in all the patients. So that is something quite significant. And behavior side effect aggression was seen in about 26%. So this is the last, I think, slide from that continuation of same study. So this was comparing the clinical trial and real world scenario. So what they have compared that in the real world scenario also. So mean dose given was at 7 milligram per day, and seizure freedom rate was about 55% on monotherapy. And in the another study, this again showed that retention rate was about 50%, even at 2 years. And seizure freedom rate was only 2 patients covered that long period of 22 months. So most of these patients had refractory epilepsy and they were doing well on monotherapy. Thank you.
Okay, thank you, Atma,
Just
for
to add on one more line from my side, sir, about my own experience in last 3-4 years. It must be more than 100 patients by now. And what I can say is none of the patient was a monotherapy, all were add-on only. And initial about 2/3 of the patient were add-on after 3 or 4 or 5 drugs only. And among those patients also, I can say about 15% or 20% patient had very good response. And about easily 10% patient became seizure free. Now, we being a bit of early add-on means after 1-2 drug or so, the response is a bit better than adding after 5 or 6, which is expected.
Okay, Atma, thank you for summarizing the evidence as well as your experience. Now, I think we have 3 talks, and I would, in the next 1 or 2 minutes, will summarize what are the evidences for the Perampanel. So, in the different headings, so one is the pharmacodynamics or mechanism of action. So it has been proven, or we all know that it has a novel mechanism of action. It is a AMPA receptor antagonist. And because of its novel mechanism of action, it might work synergistically with almost all the other anti-seizure medicine. And especially the drug which works through the GABAergic medicine like clobazam or this. So it may be a good combination therapy, maybe a synergistic therapy because of this unique mechanism of action. Coming to the pharmacokinetic, it has been summarized that it has a very long half-life of 4 days, and that is why it has to be titrated very slowly. So once you increase from 2 milligram to 4 milligram, it has to be done every 3 weeks or 4 weeks. Otherwise, the problem of behavior side effects and maybe more. And secondly, it may be very useful in the patient, especially in the young patient, as Lakshmi was mentioning, adolescent patient who maybe have a problem with the compliance. And in those patients, even if they miss a 1 dose, probably level will not fall much. So it may be a useful pharmacokinetic as far as the molecule Perampanel is concerned. Regarding the patient population, it has been shown that although it is approved for children more than 4 years of age, it has been shown to be effective in both the children and adults. And most, I think, fruitful part is that it is useful in all types of seizures, including focal seizures, focal with bilateral tonic-clonic seizure, and primary generalized seizure, including myoclonic absence seizure and drop attacks. So it is a broad spectrum of action, and that is why it may be useful. We don't have a molecule, especially higher number of molecule in the patient with the symptomatic generalized epilepsy syndrome like Lennox-Gastaut syndrome or progressive myoclonus epilepsy. So in those cases where they have a polymorphic seizure, I think it may be quite helpful molecule. And its efficacy, although almost all the previous drugs, when you see the trials, the seizure freedom rate varies from 3 to 4% in all the trials as add-on therapy. Here, the seizure freedom rate of maybe 8 to 10% is quite promising that it may be useful in a group number of patients with refractory epilepsy. We have to be careful of the behavioral side effects, which may be sometimes quite troublesome. So that is the one aspect probably we have to think of, and probably because of that, in a monotherapy, still it may be a way away before we have much more experience. But I think it is a good drug for the add-on therapy. So with that summary, I think I will invite our two panelists, Professor Murthy, as well as Neeraj, to share their experience. I will start with Murthy sir. Sir, what is your opinion about Perampanel, and what is your own experience about Perampanel? Sir, you have to unmute yourself, sir.
It is a broad spectrum activity. It has a broad spectrum activity, mainly shown to be very effective with focal onset with bilateral tonic-clonic seizures. It is very effective. And the so-called GTCS in generalized genetic epilepsies, what we call it primary GTCS. These two, we have good evidence to say it. It seems it works in all seizure types. If appropriately patient is selected and dose is escalated very slowly. The two conditions, one condition which none of the speakers mentioned is it has a good action in refractory status epilepticus. We have good experience in it, and what nowadays sometimes we do is if the patient fails, still gets breakthrough seizures with midazolam and ketamine combination, we do add Perampanel in very, very high doses. Even up to 36 milligram people have given it. And our experience is very, very good. I will give one example. We had an elderly gentleman with Epstein-Barr virus encephalitis. He has very, very drug in respect to refractory status, super refractory status epilepticus. And we added as a desperately about 12 milligrams of Perampanel. Within 24 hours, we could control the seizures and with good EEG response also. That is one example. Other example I would like to share with you is we had one patient who is a JME patient. He responded very well to valproate, but he developed pancreatitis. Sodium valproate can cause pancreatitis. So we have no other cause except pancreatitis. Then we shifted to him to levetiracetam, but he continued to have myoclonic jerks as well as GTCS. GTCS are very violent GTCS. Then we slowly escalated Perampanel in addition to levetiracetam and slowly escalated to 6 milligrams. Now he gets one. He came only 2 days back for follow-up. One seizure once in a month, but that too very violent seizure, GTCS. So now I escalated the dose slowly to 8 milligrams. We see how he does it. So it is these are two situations I would like to share it. Otherwise, other indication, most of people have shared their experience, and similar is our experience.
So that is one thing, sir. In a patient with adult patient with JME or primary generalized epilepsy, valproate fails. We don't have much of things to, or many other drugs will not work. So it may be a good option.
In that patient, both myclonic drugs and GTCs, myclonics almost disappeared.
So it may be a good option in patient where the valproate is not working, and especially women of childbearing age where you cannot use valproate and other medicine. Although we still don't have the data with Perampanel, but I think soon it will be available, and we'll have probably some option to choose in women of childbearing age. Neeraj, what is your thought on Perampanel, and what is your experience of?
Sir, I have used it in more than 60 patients who were really drug resistant epilepsy to begin with, and they were on multiple AEDs, more than 4 or 5. Initial few cases, there was a problem with behavioral side effects were too much, and aggression was a major issue, and many of them they had to initially discontinue. It was because the recommended guidelines initially were to titrate every 2 weeks. Then I changed the policy, and when now we increase it every 3 to 4 weeks, like considering as it is, because it was a drug resistant scenario, counseling them. After that, the behavioral adverse effect definitely went down, and at least in 10 to 12% cases, it really helped a lot. And GTCS definitely came down. I have used in some 4 or 5 LGS where their drop attacks also significantly came down. Although they continued to get those CPS, but then those precipitous drop attack have come down. As far as status is concerned, I have tried in 2 cases. One of them was FIRES and one of them was de novo refractory status. And one of them with 32 milligram after the last discussion with Murthy sir only a few months back. And one of them, it worked. So I don't have, I don't know this myoclonus and all. There is a recent literature that it says it has a good effect on it has a good
I have one comment.
Yes, there is.
The two unusual side effects I have seen is one child developed, teenager developed vivid dreams, very frightening dreams. That is one unusual. Another child became very abusive, very abusive. So these are 2 unusual, maybe culture based, culture related, very abusive, very abusive.
That happened, sir, with one of my children initially when I just hiked it up from 2 to 4 after 2 weeks, and then.
So behavior problems are really a concern, I think, and probably more data becomes available about the titration and all these things. But and this was why it prevents us from using as initial monotherapy. Otherwise, it is a good drug for including the broad spectrum of mechanism in this. So use in status epilepticus, how do you use it, sir? Because it is a very long half-life.
I give nasal RT tube. We give straight away a very high dose.
You give a loading dose of maybe
14 to 18 milligrams.
Loading
if
dose.
It doesn't respond, we go up to 36 hours.
Okay, sir.
It's quite safe because once he comes out of status, we can rapidly de-escalate the drug.
Okay, sir. One of my experience, at least I have found it useful in Dravet syndrome. Majority of I have used maybe in 4 patients of Dravet syndrome who were not responding to any other drug, and topiramate was producing hyperhidrosis and increased temperature, and they were not responding to the valproate lamotrigine combination in this. At least 3 of them, Perampanel produce a good benefit. So it is a drug which has a broad spectrum of action, and especially in patients with epileptic encephalopathies. Lakshmi, your views on that?
Yes, sir. Like literature review again shows a very good efficacy in Dravet syndrome as well as in many other types of epileptic encephalopathies also. So as of now, I have not used less than 4-year-old at all. One of the problems here is like we don't have a solution. Like a solution is available in US market. That is why they are able to use it for many of these kids. But the tablet is quite a hard, tough one, and it's difficult. And how much it will work by crushing and giving it, we don't know. The same problem will be there for the status epilepticus also, but apparently it works through that pathway. But I have not used it less than 4 years at all as of now.
I use it, although it's off-label use. But when you have nothing else, I think I use it. I think company people are listening, and probably they will come out with a solution. Another good news is that with now the cost is not a problem with the introduction of the Indian pharma companies and Intas and Perampa. I think cost that was the major concern. No, it was one tablet was coming at 35-40 rupees, and so this was a major concern, and we could not use in majority way our Indian patients. So cutting the cost, I think it has really will be beneficial, and across and there we will be able to use in a more number of patients. I was skeptical actually initially. I'm a bit conservative, so I start usually using newer medicine at a lot. But I think I am convinced that it is useful in the patient with the resistant generalized epilepsy, epileptic encephalopathies, and difficult to control epilepsy. And although gradually it will go as a first add-on also, I think that is the what we have to. We'll take some comments from the Nayak sir also. He started the discussion. Nayak sir.
Yeah. Hello.
Yes, sir.
Yeah, that's a good point. Yeah, I think I must have used it in about maybe 150 to 180 patients or something like that. That's my, yeah, I mean, the responder rate, as you said, one striking thing is there are, in about a small percentage, I think I can remember about maybe 5 or 6 patients whom I could convert to monotherapy over time. That is, you start as adjunctive, and then you find that there's a good response. And you slowly start tapering the others. And there's one person with the severe reflex epilepsy just touches his lip and he'll just have a drop like that. And then that chap responded extremely well to 10 milligram of Perampanel. It completely stopped. Absolutely no this thing at all. So I could then stop lamotrigine and the other, I think it was zonisamide, something else, completely stopped. Another very difficult to control juvenile myoclonic epilepsy in an adult. 4 different medicines, valproate at 1,200 milligram, other things, levetiracetam, brivaracetam after that, and then all that. And then moment this was added, he stopped getting, and he would get these shoulder dislocations and all that. Now he's only on, just on, I could just bring down all other medicines, and he's now only on Perampanel. And at about 8 milligrams, he's now completely seizure free. So I think sometimes you get very dramatic results, but then we tend to use Perampanel only in very difficult to control epilepsies. So that's one of the, as always, I mean, it's like trial by fire for any new anti-seizure medicine. You use it in the most difficult ones. Then you'll try to find out, okay, yeah, there is a group of patients whom you could use it earlier as you gain more experience. And then you start finding out, okay, there is a group of patients who will come down to monotherapy. And that is how it is happening. And so now we know at what point you should start as first line. I mean, that's not first line in the sense the first adjunctive therapy as a first add-on. So that's the kind of experience we get as we move forward. I think that's what it is. And this discussion today makes us feel that we can probably use it earlier than what we were familiar with, especially now with the cost coming down. So we are going to gain more and more experience with this molecule because we'll be able to use it in a larger population, gain more experience. And many times, even with more milder epilepsies, they may respond very well to small doses, as maybe as a duotherapy or a monotherapy also. So let us see. That's my comment on this.
Yes, sir. So thank you very much for summarizing, and you made my job easy. So we can, with all this, we can say that it is not another molecule, but probably a molecule with a difference. I think this is what has come out of this, and because of his unique mechanism of action and this broad spectrum of action, I think. Yeah. If anything, anyone else wants to add, Murthy sir or anyone?
Nothing.
Okay. So with that, I think we have covered a majority of aspect, and we have summarized the molecule and its utility as of now, and what is the future holds for it. I think it's a quite promising molecule in the future, and we will see basically we'll at least no company compares head to head as a first add-on. But if suppose somebody can take over as a compare with the first add-on with the commonly used drug, it will be remarkable trial to do it. So I think with that I would like to end the discussion, and I will request Mr. D'Souza from the INTAS to propose a vote of thanks.
Also be at the forefront of knowledge sharing partner for the benefit of the medical fraternity. In this context, I will
Can't hear you. Hello?
Can you hear me?
Your audio is very
Your voice
feeble,
is
Mr. D'Souza. Voice is
yeah, it's
breaking down.
broken and it's feeble. Lot of background noise, static.
Now, can I?
Yeah,
Am I audible now?
better.
Better.
Good evening, doctor. INTAS has always been at the forefront as a knowledge sharing partner for the benefit of the medical fraternity. In this context, I wish to wholeheartedly thank Dr. Chaturabhuj Rathore for arranging such a short notice today's webinar on real-world experience with Perampanel. I wish to thank the galaxy of eminent speakers, namely Dr. Dinesh Nayak, Dr. Lakshmi Narayan, and Dr. Atmaram Bansal, as well as the distinguished panelists, Dr. J.M.K. Murthy and Dr. Neeraj Baheti, who truly have made this webinar an illuminating one for all the participants benefit of the epilepsy patients treatment. A big thank you to all the more than 200 participants in today's webinar that has helped in making it a grand success. A big thank you to all and a good night to all of you. Thank you very much, sir.
Thank you.
Thank you, Mr. D'Souza, for supporting this education initiative. And I think from all of us, we thank you, and we thank you all the participants for their patient listening. Thank you very much.
Thank you.
Thank you, sir.
Thank you.
Good night.
Good night.